Manipulation for sciatica. Comparison of side posture manipulation to microdiscectomy. Please join me in reviewing a very significant publication that may turn long-held beliefs on their head. There's a paucity of literature on chiropractic manipulation and radicular leg pain. Why? Seems logical. Why would you expose a patient with a known nerve root problem, most often due to disc herniation in the lumbar spine, to a potential mechanical risk that would worsen that problem? Almost everyone assumed that this would be in essence reproducing the mechanism of injury. Yet in the literature, there have been debates within the profession about the actual danger of side posture manipulation with regard to disc damage. Polls were conducted, commentaries published, and theoretical defenses mounted on both sides, arguing for or against its use. In the general chiropractic population, it appeared that many chiropractors admitted they were willing to try side posture manipulation, especially if the lumbar spine was kept in extension to lock out the facet joints. Some biomechanical models suggested that in this posture there would be a limit to the amount of rotation that could occur at the disc, protecting it from further damage. But because the predominant belief was that it could potentially cause damage, little real research occurred, with the exception of an occasional study, such as the Cassidy et al. Study in 1993 in JMPT, which was a case series indicating a 50% success rate for manipulation and sciatica presentation. There was also the Haas et al. Study that demonstrated improvement for patients with leg pain below the knee, and the more recent study by Santilli et al., which we'll discuss later, that also showed improvement with side posture manipulation. But what if patients had already failed a conservative trial and their only other option would be surgery? Well, this opened up a research opportunity that could mitigate the initial concern and still provide an answer to the value and safety of side posture manipulation for sciatica. So here's the study published in 2010 in JMPT, Manipulation or Microdiscectomy for Sciatica, a prospective randomized clinical study by McMortland, Suter, Kasha, Duplessis, and Hubert. Some context first. We might be inclined to think that sciatica is common given the patients we see, but in the general population, sciatica due to disc herniation is seen in 5.1% of men and 3.7% of women. Although physical factors play a role in the onset, psychosocial factors, heavy labor, and obesity are more related to prolonged recovery and disability. What is sciatica anyway? And that depends on who you speak to and which study you read. Of course, it generally means pain extending down the back of the leg in the distribution of the sciatic nerve. But is it a peripheral neuropathy based on the name of a peripheral nerve? Or is it a nerve root, in other words, a radicular-based entity? This study at least attempts to identify nerve root levels so that the use of the term sciatica is less relevant to the discussion. Well, let's move on to what is known about sciatica and manipulation. You might be thinking, what about that Italian study from a few years ago that many chiropractic reports touted as showing manipulation was effective for sciatica? Well, good memory. There was a study by Santilli et al. Published in the Spine Journal in 2006 entitled Chiropractic Manipulation in the Treatment of Acute Back Pain and Sciatica with Disc Protrusion. Although there were some intriguing results that certainly should have opened the door for a larger, better designed study, there were several caveats with this study. The biggest question is, what caused the radiation or sciatica in the patients in this study? Well, why ask that question if they had radiation down the leg? Well, the flaw here was that the diagnosis via MRI was for disc protrusion, and in fact eliminated what the authors state as disc herniations that would have warranted surgery. Therefore, was this radicular pain or radiating pain due to sclerotogenous referral without nerve root involvement? This might also explain why the manipulation group did better than the comparison sham manipulation group, but also explains why the sham group did well on other measures other than the pain-free percentage decreases, which to the defense of the study was quite high for the real manipulation group. Scientifically, the criticism was of course that there was no control group, and that the improvements, especially if the cause was not nerve root compression, were in large part natural history. So back to the current study. How did they improve on the weaknesses of the Santilli study? Well, let's look at the patients and the criteria for using the term sciatica. Patients were not acute, as in the Santilli study, so natural history has been given its first chance to have its effect. Secondly, the patients had to have failed 3 months of conservative management. Failure was either from analgesics, lifestyle modification, physiotherapy, massage therapy, or acupuncture. Patients were included if they had not only objective signs of nerve root involvement, but also had to have leg-dominant symptoms. Evidence of correlated MRI findings of nerve root involvement due to disc herniation. Levels L3, L4, L4, L5, or L5S1 involvement had to be demonstrated, although only one patient had L3, L4 involvement, as one might expect. Exclusion criteria were if there was less than 3 months of medical management for radicular symptoms, if there were factors that would influence communication, such as non-English speaking, substance abuse, cognitive impairment, if there were risk or complicating factors such as osteoporosis, spondylolisthesis grade 3 or 4, prior surgery, corticosteroid use, major neurologic deficits, anticoagulant therapy usage, etc., and any concurrent treatment with spinal manipulation at the time of enrollment. A couple of interesting findings for me were that the percentage of smokers was fairly standard for this Canadian population. Given the literature regarding an independent risk association between smoking and disc herniation, one would expect that the percentage would be higher. Another important feature is that only one case in each group was workers' compensation. Almost all others were private, self-insured. Only 1/3 of the patients were involved in manual labor. There were several outcome measures used, including the McGill Pain Questionnaire, the Aberdeen Back Pain Scale, the Roland Morris Disability Index. Follow-up was by phone at 3, 6, 12, 24, and 52 weeks. So this study is comparing side posture manipulation to a newer form of surgery, microdiscectomy. So let's review some of the specifics about microdiscectomy to see what it's about. Laminotomies are performed as needed to allow visualization and removal of the herniated material with minimal disruption of surrounding tissue. This means a window is cut out of the superior lamina, usually a few millimeters or so. The nerve roots are retracted to allow access to the herniated disc. Both sequestrectomy and intraannular discectomy are performed. In this study, patients remained in hospital for 1 to 2 days. How do you decide to side posture or not side posture someone with a documented herniated disc? The researchers were very pragmatic and used an approach that is similar to what anecdotally practitioners also discuss using. First, if positioning causes exacerbation or peripheralization of the leg pain, no side posture was delivered. Second, if the patient simply couldn't tolerate the position, the side posture manipulation was not utilized. Although most might have assumed this was a surefire way to eliminate all patients in this treatment arm, it turns out that only 2 out of 20 patients were not able to tolerate treatment. Treatment frequency averaged 2 to 3 times per week for the first month. For the next 3 to 4 weeks, treatment frequency averaged 1 to 2 times per week. Then, unique to this study, at 8 weeks, treatments were scheduled based on patients' symptoms, so that an initial treatment holiday of 2 weeks was given. If the symptoms did not deteriorate, no treatment was given and the treatment holiday was doubled to 1 month. If symptoms deteriorated, treatment was given and a treatment holiday of the same length of time was scheduled. This was continued until the patient was stable with a 2-month treatment holiday. It's important to note here that at 12 weeks, patients were allowed to cross over if there was no success with their original assignment. The researchers did use, though, an intention-to-treat analysis. There was some common ground between both treatment group assignments. Both groups received educational materials that included do's and don'ts and self-care recommendations, and each group also received 6 supervised rehabilitation sessions of exercise with a focus on core stabilization. Secondary analysis included 4 groups: successful surgery, successful side posture manipulation, surgery crossover, and manipulation crossover. As a summary, 60% of patients failing medical management for lumbar disc herniation-related sciatica demonstrated some benefit with side posture manipulation equal to those who underwent microdiscectomy. Patients who failed to benefit from side posture manipulation received benefit from subsequent surgical management. However, those patients failing to receive benefit from surgery did not benefit from subsequent management with manipulation. When dealing with sample sizes that are small, using percentage success rates might be a bit misleading. Let's restate the results with numbers of patients. Remember, there were 20 patients in each group. This means that 12 patients in the manipulation group showed improvement, 8 crossed over to surgery, and all of these patients had improvement. The 3 patients who failed surgery did not improve after crossover to manipulation. Some weaknesses are, of course, the lack of control group. Next, the researchers did not provide enough data. For example, in one table, data was provided for the 12-week time frame, but when data was provided for the full 52-week time frame, they switched to graphs. The difficulty here is the data is not explicit, meaning the size of differences is lost in the data division sizes. For example, differences in the Aberdeen pain scale seem significantly better in the surgical group, but the specific numbers are not listed. Only points on a graph that might be 32 for the manipulation group and about 25 for the surgery group. But this is only a guess because the actual numbers are not given. The same is true for the Rowland-Morris, where there appears to be about a 2 to 3 point difference between the surgery and manipulation group in favor of the surgical group. Most importantly, the researchers calculated that they needed 70 patients in each treatment arm, and yet were only able to have 20 in each. This was after 4 years of recruitment, which indirectly transforms this study into a pilot or feasibility study. In other words, it may not be feasible to perform this study at one site. Multiple sites are likely necessary to create a large enough sample of patients in each group to generate a high-powered study. 2 other points. Although not really dealt with directly, it appears that spinal manipulation for patients with disc herniation was a safe approach in this study using the precautions listed. Secondly, although not directly discussed, the cost differences between these 2 approaches would likely be substantial. Although the cost of microdiscectomy is difficult to pin down, educated guesses are minimally around $25,000 and likely more. If we take the protocol used in this study and calculate out the maximum use of manipulation services over 1 year, it would likely not exceed 30 treatments. If a guesstimate of approximately $40 per treatment was used, the total cost would be well under $1,500. Finally, even though this was a small study, it might serve as a pilot approach for application in appropriate settings. The algorithm might be as follows. Patients with sciatica due to disc herniation should have the option of a trial of manipulation using the cautions utilized in this study. Those who fail an initial 12-week trial should then be directed to microdiscectomy. Let's hope that this study triggers an interest in both applying the study's approach in various clinical settings and stimulates the funding and interest for a much larger study that would provide stronger evidence for its conclusions.